from Rupert today?
I am in Prince Rupert, yes.
Okay, great. So how have things been for you for the last couple weeks?
Um, uh, like generally speaking,
A couple things. So I guess generally speaking, and I know in particular, I'm keen to hear about your blood pressure, as I know we had, made a couple changes at the last appointment, or the main change as far as increasing that amlodipine. Did you have a chance to do that and pick out the prescription?
yeah. So generally speaking, I'm still struggling with digestion issues causing chronic inflammation, which I'm sure affects blood pressure. And now to answer blood pressure is yes, I did after we talked last time bring it up to 7.5. And in
Mm-hmm.
the last few days, I also have been starting to bring down modafinil in case, that's,
Mm-hmm.
and then
Yeah.
checking it not on a daily basis, but the last time I checked it and it's sent to my email is it's still in the high.
Okay, so a little bit above range. And are you doing okay with the lower dose of modafinil? Because I know that, we're considering the side effect of it, but of course you're taking it for other reasons as well. You've been managing okay with the decreased dose?
Um, a lot of doctors that knew me in the past for long periods of time know that for me it's as needed modafinil.
Mm-hmm.
Like
Mm-hmm.
right now, I don't need that much of it because
Mm-hmm.
really I'm not challenged with anything in my life that's worthy of,
Yeah.
having concentration.
Okay.
But if it was, I still have some. Like, for example, if I think I need to be more alert for, let's say, a long driving shift or something like that, I can
Mm-hmm.
always use that just to be safer. But
Yeah.
otherwise, I don't really need it. It's more like it
Mm-hmm.
improves the quality of my life. But again,
Mm-hmm.
fatigue and concentration is in big part again affect the cause of, I mean, a symptom of digestion issues, which are not being addressed by anybody, I guess. So
Yeah, and I always say and I might have mentioned this last time, tough in medicine in the sense that we're sometimes good at telling people what things are not, but not always what they are. And I know that you've seen the gastroenterologist, and I don't have access to the notes, but I know you're mentioning some frustrations with kind of their impression of things as well. And like you mentioned, blood pressure is affected by many facets of the body, our environment, our genetics, what symptoms we're having, and can really vary day to day as well. Um, and you mentioned your numbers are a little bit up. It's okay if you're not able to recall, but do you know kind of what numbers you had been getting in the last or the kind of most recent readings?
yeah, the average again I would say is around 151, 92 or something like that. But
151,
again,
92.
but again, it could be in a few days is when it might start to go down a little bit. But I mean, it might not go
Yeah.
down that much, and I don't want to just medicate because there are causes to this that I'd like to investigate. And answering about the gastro specialist is I didn't see them. They just talked to me on the phone, and they did very little to prove their specialty or a motivation to exercise their specialty with a virtual clinic patient or just somebody on
Hmm.
the phone. So
Yeah, and again, I can't speak to that specific encounter, but I was sorry that that was your experience with them. With blood pressure, like you mentioned, it does come up from a lot of different issues. The biggest indicator is often someone's genetics as well. We know that the artery walls lose their elasticity over time, and some people can have more of a genetic predisposition than others. Certainly, we do know that sodium restriction in diet, not excessively, but being mindful of limiting processed foods. We know exercise helps, but for the vast majority of people with diagnosed high blood pressure, lifestyle measures, even if people are doing things perfectly, are often not enough on their own unless it's very mild, very, very mild blood pressure and often kind of onset 60s, 70s. And I would say for later onset, it's sometimes easier to manage because there's often a bit less of a genetic component to it. So our go-to beyond the lifestyle recommendations is medications. Now, I recognize your hesitancy to just scale up the medications or the doses. However, being frank, majority of people do need to be on at least two medications, sometimes three, to get their blood pressure under control. Actually, I wouldn't say the majority, but a very significant number.
hmm
Um, So there's a couple options here. You mentioned, it can go down in the next few days. There's no, I say, when it comes down to blood pressure, we're thinking big picture, getting the numbers at a good place over the course of months to years. A week or two here and there of it being above target is as long as it's not over 200 or something very, very high, is okay. So I bring that up in the sense that I think it's reasonable to either one, increase the dose of amlodipine to the max 10, two, keep amlodipine the same and add a low dose of a different medication for blood pressure, or three, not do anything and see how things kind of pan out in the next few weeks, recognizing that from a blood pressure perspective, there's not urgency to it, but it does need follow-up.
Okay, so you presented three scenarios, and it's because I can choose the one I want, right?
Yeah, I think all of those are very reasonable. Exactly. I bring those up because I think all three are reasonable and safe options. So I'm curious to hear what of those three sounds more, are you most comfortable with?
Yeah, I'll answer that very soon. I'll just follow up on the genetics. I'm not certain there is a genetic cause, and I'm not aware that anybody did any measurements on my blood vessels to see if they are causing it. And I know that some of my blood tests, including the last ones, show high levels of fat, in my blood. So, a lot of things could be impacting the blood pressure. Anyway, I'm going to go with option 2. I'm going to go keeping 7.5 and trying a low dose of a new one.
Okay. And with other medications, usually we use a medication class called, basically the medical name is ACE inhibitors or ARBs. They're a very common class of blood pressure medications. I might have mentioned this last time that the small annoying thing about this medication is that after we start it, we do recommend a blood test about 2 weeks later just to make sure that the sodium, potassium levels and the kidney function is sitting well with it. In kind of rare cases, the body can have a little bit of a reaction where the kidney function dips a little bit. When that happens, we just get people to stop the medication and we just do a different one. It's not a critical side effect. It's just more of a nuisance more than anything. But I'd say, well over 95% of people, we get the blood test after a couple of weeks, it looks okay, and people tolerate it very well. Now, the medication it's usually prescribed for this is called Ramipril. It starts just at 2.5 milligrams once a day, similar to amlodipine. And just so you're aware, because I think knowledge is power. It's helpful to have information. This medication can go up to 20 milligrams a day. At higher doses, we sometimes split it. Unlike amlodipine, that's always just once a day. So relatively speaking, we'd be starting at quite a small dose. And again, for the first at least a week of the new medication, similar to when we changed the dose of the amlodipine, I would not even bother with checking your blood pressure because it's tough to know what to make of it as your body's getting used to it. But after a week of being on the medication consistently, the same thing, just getting a handful of readings, seeing if it's coming down a bit, and then if it's not, of course, then booking an appointment, and we'd be able to, at that point, probably increase the Ramipril. Of course, we can always top up the amlodipine as well. Both would be reasonable options at that time as well.
Okay, my turn. Are you planning to come work regularly in Prince Rupert? Because if so, you could take me on as a patient. Now, to answer the other questions is the gastro specialist, one thing that he did do is notice some irregularities in kidneys, so he referred me. I don't know if I'll ever hear or get confirmation I have been referred to a kidney person. So this other medicine, you're saying that, so I mean, I don't know what the risks really are,
Yeah.
but I am very happy with doing blood tests anyways, because I'm curious about how my blood has been changing over the last few years, and it's not that hard to do around here. So yes, you're saying that the 2.5 of this new one is a low dose to start at and not to measure blood pressure. And here in my responses, here you can see my listening skills, even with a lower dosage of modafinil, is better than the average, in part because I'm trained in listening, but also because I'm making the effort. Now, yes, so the one I'm taking now, the first one, is in the morning. So this other 2.5, it can be in the morning, and maybe if it's a higher dose in the future, then I would split it up.
Yeah, so it's can be in the morning or at night. So I always say the best time is the time that you'll remember to take it consistently. So It shouldn't, cause drowsiness. It shouldn't cause, it shouldn't keep you up at night. It should be okay to take. So I guess you're mentioning taking the Modipine in the morning. You could take it in the morning as well. And exactly that. Once we get over 10 milligrams of ramipril, usually it's split, but that'll really depend on the doctor you see. The evidence of when to split the dose is a bit mixed. So we find usually once we get to bigger doses, kind of above 10 milligrams, at least that's my practice, usually to split at that point. I think technically you can keep it as once day dosing up to 20 milligrams, but in practice most people don't do that. And then to answer your question, although I will likely in the next year be back in Prince Rupert covering at the clinic, I probably won't be settling there anytime soon. So opening up a practice, unfortunately.
But like sometimes if you're there in person occasionally, but we can ask virtual clinic, can I get the same doctor? Then it's almost like having a regular doctor that can, do their own notes on a person and therefore not get, let's say intellectually lazy by trying to review everybody's notes on a virtual clinic that are not as well done as maybe the way a doctor decides to do it themselves with a patient, right?
And it's an interesting point in this, since that actually so use just for example, not for this encounter, but just if I am seeing people at the virtual clinic and I go to Prince Rupert and I work for a week, the electronic medical records, and this is an issue all across Canada, don't really speak to each other. So if I were to see you in a clinic in Prince Rupert, I would have none of the notes from that, the last couple weeks ago and today, or any of the blood tests on their electronic medical record. There's a way to get some blood test results from the hospital system. If you have access to the hospital system, which I do, and most doctors do who work in Rupert. But it's a very...
Is that something they're working on right now to kind of make it kind of more universal in Canada? And also, is it illegal for you to, let's say you are taking me on and some of our appointments on virtual clinic, to get yourself CC'd in a way that you can incorporate it to, whatever other files you have?
Yeah. So again, this is really a reflection of our medical system. It wouldn't really so for example, when I work in Rupert, I'm usually just there for 2, 3, 4 weeks at a time, and I'm covering somebody who needs to go away for a few weeks. So I'm often just covering their practice. Okay. And there's a lot of and it's interesting because you bring up a lot of very valid points, and it's kind of just reflective of the state of affairs for electronic medical records and medical sharing, information sharing in Canada. There's not a legality issue around it. It's more, about in the early 2000s, we all kind of dug ourselves a hole. This is before I was in practice, but dug ourselves a hole where everyone kind of just started getting their own medical records, and now it's such a behemoth of a cost to merge them. And beyond that, a lot of clinics like their own medical records and have opinions over what to switch to, and it's created a system. Even though it's provincially mandated, every province is running into this issue right now. No province even seems to, within their own region, be able to find a solution. Sometimes small little local health authorities will kind of find small little solutions.
Well, the solution is simple. It's to retrain all doctors in the ideology of being patient-centered, and then that's going to get done. But they don't have that.
It's very expensive for the government to make that switch over as well, though. For billions and billions of dollars at this point to merge all the healthcare systems, because they're all private companies, the EMRs, and they're very expensive, especially when you're integrating. So I could go off a topic for another day as well, because I'm mindful of time, and I want to also prioritize the issues we've been talking about today. But I definitely hear you, Martin, as far as big systemic issues with how our electronic medical records are managed from a community perspective across the country. Final
point on that, and then we have to maybe just give me an answer about the shoulder. But final point is, you know how hard it is for patients to get a copy of their file. And that's proof, again, that everybody believes they have ownership over a patient's file more than the patient themselves. When they realize this, what you're talking about is going to become easier to solve. Now, the appointment today is related, supposedly, by the person that booked it, with my results coming in for the shoulder. I went to look on Healthy Life. Nothing was found, so I thought maybe you'd want to pursue that with other testing on my shoulder. Is that possible, or?
Well, so the X-ray I was able to. I have the report here. So the X-ray was normal. Now, clinically, from what you're describing, from like the fall on your bike and the aching you have, the challenge is, and I know I mentioned this last time, that further tests don't change the management at this point with how your shoulder is. In the sense that we're again kind of getting to a systemic issue where there's limited access to things like physiotherapy. I'm not sure if you had a chance to. I think you mentioned you were going to ask at the hospital if there is any MSP covered physiotherapy.
I can say my shoulder seems to be a little bit less painful in the last week, and but I also am in my third cold of the year, so I know my repair or immune system isn't as good as it used to be. And I don't know if there is the possibility I might have lupus or something like that. I'm never getting a straight answer in the notes I get access to. So we can drop the shoulder thing for now, but thank you anyways for asking for the x-ray. And when you ask for the blood tests, make sure to include kidney again, lipids, and CBCs, everything. And when do you want me to do the blood tests with this new medicine?
The blood test is just for the kidneys and the electrolytes. Let me see the last time you had...
Check the results of my lipids.
Yeah. And I just want to see the last time your lipids were checked.
When you check kidneys, do you check kidney? Is there only one or two things they check for, or there's a variety of things you can ask for kidneys?
It's a specific kidney test. It actually checks the filtration rate. Pretty much it's a single test that shows how well kidneys are functioning.
Well, to follow up with the referral for the kidneys, I'd like it to include every kind of kidney thing because, when I go there, I don't mind getting a bit more blood taken out just to be more thorough.
Yeah. So it's a balance, right? Like, so we have to say, something for us to request blood tests off of, under MSP essentially. We have to order what we think is clinically warranted. So the kidneys and the electrolytes, and I'm even seeing here I understand you had a history of the iron deficiency, and
that was specifically linked to digestion issues, which caused problems with hemorrhoids that were bleeding for long, long periods of time.
Yeah, so I want to make sure that I think it's very reasonable to repeat your CBC. I'm also going to check your iron levels. You're not taking an iron supplement currently?
No, I believe my iron levels will be fine, but I'm not sure about kidneys or lipids, and I'm not sure about pancreas. My pancreas, I think, has to be looked at a bit more. I know that there's little issues with liver. Also, even though I've never been a person that drinks, my father was. But for me, there's still hepatitis-related things. Although I am immune to that because of vaccines, right? Having a second dosage even 10 years ago. So for me, there's still things with organs here and there that are kind of off. But I think the pancreas, should be looked at more, and I'm not sure that was ever focused on.
So the pancreas is not something we generally often check. It's usually checked in the emergency department with people with very severe pain to make sure they're not having acute pancreatitis. There's not that blood test outside of that context is not very helpful.
Can you tell me
something we usually do.
If there's high levels of fat in blood, what organ would be responsible for that more?
So it depends. If you're meaning like triglycerides, which is a part of the cholesterol blood test, and we're checking a very specific type of fat there, or a part of a fat molecule more specifically, that can be caused by gallstones sometimes. It can be affected by diet. It can be affected, usually it's not directly related to the pancreas, but kind of how the pancreas interacts with the outlet of the gallbladder and what we call the biliary tree.
Okay.
But those things are more.
Is it easy to check gallbladder in the blood tests?
No, we don't generally check for gallbladder markers. It's usually in the context of severe pain that we're making sure people are having a gallbladder attack.
My brother in the last year has had a stone, and I think they're not doing anything with it now because the pain is manageable and it's not interfering. So that could be something that's a little bit genetic. I'm not sure if I've ever had something like that.
Yeah. Yeah, and often what it'll be is, at least the typical presentation for that is pain on the right upper side of your abdomen, just underneath the ribs. That happens about 30 minutes after eating something greasy, and it's an hour or two of severe kind of waxing and waning pain that kind of spreads around from the upper right side.
No pain for that for me. No.
Yeah. So, and the markers often, unless a stone is jammed, causing a lot of pain, kind of then they go up. But even with people who have stones who just sit there and aren't having bad symptoms, usually the numbers are normal anyway, which is why we don't really check for it in that way. So I will repeat your cholesterol levels and your electrolytes, and I will put a CBC just given your history of anemia last year. I think that's, I know it was directly related to that, but just to the hemorrhoidal bleeding, but just to make sure that that's coming up nicely.
And whatever kidney tests will help even the specialists, right, that might contact me.
Yeah, and of course the specialist, so I'm going to do the main kidney marker and electrolytes, and that's generally, there's not a bunch of other tests there's some very kind of rare esoteric tests that will pretty much only
so doctor
will order.
I can go pick up that new medicine today and start it tomorrow morning. So when would you want me to do the blood test if I start the new medicine tomorrow morning?
So I would say 10 to 20 days after starting it. So
Okay.
1.5 to 2.5 weeks after starting it. Anytime in that window is okay.
Okay, so so are you sending it now, the requisition, but I'll wait that time before I go to the hospital?
Exactly. Yeah. So I'll send it to the Prince Rupert Hospital lab.
Well, thank you very much.
Okay. And then also just a heads up, the way we send in prescriptions is I send a task to one of our admin to fax it off to your pharmacy. Depending on how busy they are, sometimes they do it 5 or 10 minutes after, sometimes an hour after. So I would just wait a couple, 2-3 hours, call the pharmacy to see if they got it. But certainly within a few hours, it should be sent there for sure. Because I task it before I even call the next person in my schedule here.
Yeah, I have noticed them, and sometimes they call me when they get something
Perfect.
new, so they might do that. But I am wanting to go near there today, so I'll go check anyways.
Perfect. Okay. Well, I'm happy to touch base today, Martin. I hope you enjoy the rest of your Saturday.
Yeah, you too. Thanks a lot. Have a good one.
Take care. Bye.
Bye-bye.
You too. Bye.